Dr. Ali Eqbal. Welcome back to Everyday Medicine. We very much appreciated previous discussions, which were about complex polyps. That was extremely helpful. We'd now like to pick your brains a little, Ali, on your approach to inflammatory bowel disease and how we should be surveying patients for dysplasia. It's something that is very important. We seem to be seeing more and more patients with inflammatory bowel disease in our community, which we're managing quite well with biologics. Does that change our surveillance if they're nicely managed? Many years ago when I was training, this comment that if it had IBD for 20 years, there was about a 20% risk of colorectal carcinoma. This is ulcerative colitis we're talking about, which I never really believed those figures. They always seem to be way higher than I ever observed. And I think the figures have improved a lot, but it still is a concern for patients. Tell us about what we should do. Take us from here, IBD, run through our surveillance. Please.
Yeah, thanks, Luke. No, it's great to be back. Yeah, so I think, to be honest, the points you've just raised were actually really spot on. And I think that's probably been most recently reflected in the most recent up-to-date guidelines, which the British Society of Gastroenterology published earlier this year, well, late this year, I should say. And I think that's really a nice, robust document that summarises all the aspects of IBD dysplasia. And we're not going to always have time to go through all of that today, but we can touch on some of the important parts of it. I think first and foremost, IBD dysplasia, surveillance, and I think management in general, it's no longer, again, the role of just the gastroenterologist. And you'll hear this term thrown around a lot, but it really is a multidisciplinary team that's needed to look after these patients. So that includes the managing IBDologist, likely an advanced endoscopist if you were considering endoscopic resection, histopathologists and surgeons. And I think together you make the decision again as to what the right strategy or management is for detecting IBD dysplasia for this patient. And so that might be local resection or that might be surgical management. And so you have to consider all those things. In terms of how we first begin, it's about risk stratifying that patient. And like you said, I think previously, many years ago, that risk of IBD dysplasia was significantly elevated. But actually, I think most recent evidence suggests that it's probably decreased in recent times. And that, I think, invariably is associated with a better management of inflammation. And there's certainly a strong correlation with severity of inflammation and dysplasia risk. So when we talk about risk assessment, I think it's about determining what that degree of inflammatory burden has been and is it under control now. It's whether or not they've had any previous dysplasia, so whether it's colitis associated dysplasia or lesions that have been resected in the past, or whether they have other risk factors such as primary sclerosing cholangitis, which, as we know, has a significantly elevated risk of dysplasia. And then, of course, things such as family history. And so based on those particular factors, you can then determine whether or not this patient needs yearly or 3-yearly endoscopic surveillance. And most recently in the BSG guidelines is if we feel that patient has a low risk, i.e. very low inflammatory burden or history of inflammatory burden, and has had multiple colonoscopies that confirm endoscopic or histological remission, that actually their risk of colorectal cancer is probably at the baseline population risk. And so age-appropriate colorectal cancer screening would be appropriate for the patient, or a scope every 10 years. So I think that's probably been the most recent latest development is that identifying that actually those patients with, I'm sure you've been before, with quite benign disease course, even if they've had it for 20 years, probably don't have that previously suggested risk of dysplasia. From our perspective for gastroenterologists and perhaps even for GPs, there are some nice IBD dysplasia calculators online that give you a bit of an estimated risk based on, as we said, those factors. And then that can then help you determine that surveillance interval. So that's sort of talking about surveillance. I think the most important thing as gastroenterologists, though, is going to be how do we do it? And there's always this conversation as to whether or not we're considering virtual chromoendoscopy or dichromoendoscopy. At this stage, the evidence still is slightly in favour of dichromoendoscopy. However, I think it seems to be clear that with the ANVIT and the advances we've made in our endoscopic techniques, particularly with high definition and virtual chromoendoscopies, I think we are quite good and we have the ability to detect these lesions with virtual chromoendoscopy. What do? I'm a big fan of dichromoendoscopy, and I think that's probably because what my interest being polyps is we do like to spend a lot of time looking at pit pattern. And I think that's really important. And I think it comes in hand is what we're seeing in terms of dysplasia and IBD is similar to what we're seeing in polyps. And so that's why I like dye.
Tell me a little bit about this. What dye are you using?
I like to use indigo carmine.
Yeah.
But the other option is methylene blue. And I think both of those substances really help accentuate pit. And that's really what we're trying to do. We're trying to accentuate abnormal morphology and dysplastic pit structure. So, areas that look adenomatous in the mucosa.
Which can be hard if you just brush past them quickly with just plain light. It's a bit like endoscopy on the skin, isn't it? What we're doing is sort of magnifying the area in a way.
Yep.
Doing whatever we can to highlight areas that might be abnormal. Yeah.
Exactly.
But it's time consuming, Ali, and a lot of people don't do that in practice.
So if we come back to the guidelines as well, there's one of the, I'll probably skip this step, is we actually have to prepare the patient appropriately. And that is plenty of bowel prep, making sure that patient is really clean and perfectly clean so that we don't miss lesions. And that we actually allocate enough time. We really need to consider, and we really should be giving these procedures for dysplasia surveillance a couple of extra slots in your practice so that you're giving them the dedicated time that they need. So I think your chromoendoscopy probably adds a little bit of length to the procedure, but I think it's important. And, obviously, as we've said, that we're going to be doing it once every so often, and we should be doing it right. And another concerning fact that we saw was we do see quite higher rates of post-colonoscopy colorectal cancer in these patients. Yeah. And so what we know is that they actually don't traditionally follow the standard adenoma polyp pathway. Yeah. There clearly is other dysplasia pathways or mechanisms involved. So I think we give it that extra time, give it 45 minutes, give it extra prep if we need to. I think from a practical perspective, look, I don't use dye for every single dysplasia surveillance, but if I know there's a patient with a scarred, shortened colon, lots of pseudopolyps, or in patients who've had previous dysplasia, and certainly in patients with PSC, that's where I'd be pushing to use some sort of dye chromoendoscopy. In saying that, I think virtual is on its way, but at the moment, the dye is still the superior.
Tell us a little bit about the virtual approach, because AI is coming into all walks of life.
Yes.
No matter what one's profession is these days. Tell us a little bit about how the virtual might work and how you could see that may be affecting the future of detection.
Most of the current endoscopy companies have some form of virtual chromoendoscopy. So you have narrowband imaging with Olympus or blue light imaging with Fuji, and I think iScan with Pentax. But basically, it's sort of some subtle differences in the absorption of various lights that then make sort of distinct vessel patterns obviously. So with NBI, for example, and with BLI, is you aren't seeing the vessel caliber, the vessel shape and the regularity. And that allows you to determine whether we think this is a low-grade adenomatous lesion or a high-grade lesion or a deeply invasive lesion. So I think all of us have probably become used to training and working with these now, and we're seeing that they work really well and really important for dysplasia detection. But really, NBIs and LCI, I should say, and BLI are validated in determining what that vessel caliber is, and classification systems we have look at vessel caliber, so JNET classification or NICE. But when we want to look at pit pattern, if we're going to look at, for example, the Kudo pit pattern, that helps us to determine, again, gives us more evidence to determine whether we think this is low or high grade, then you should think about using a dye-based solution. So it's a combination approach to using both of those things, but I think they're both valuable in making that endoscopic assessment. And I should also say, even before we've used virtual chromoendoscopy or dye, as I'm sure you've done it before, you're just looking at something under white light and something catches your eye on that withdrawal, something in the corner, you've picked up something, and that's probably the first thing that then draws your attention to it. And then you focus on it and use those adjuncts that we spoke about. But, with experience and with time, there really is something that just catches your eye. And I think it's really hard to really appreciate that until you've had enough numbers under the belt.
Well, I think that's right. So there's different methods of assessing an area that is dysplastic. What's your approach there? It's suppose low grade versus high grade. What are you going to do in regard to tackling that?
Yeah, absolutely. So look, from I think the previous podcast that we spoke about was lesion characterization.
Yes.
And I think we just have to have that same approach to this. So what is the shape of the morphology of the lesion? What is the size? And already you're going to have some sort of appreciation of the risk of covert cancer Although in IBD, as we know, is once a lesion's greater than 20 milliliters or more, then that already in itself will have a high risk of covert cancer. Generally speaking, in the colon, any patient with IBD associated dysplasia, you would need to consider an en-bloc resection. Before we come to resection, what we generally try and do is say, can we see the borders? So is it a lesion with discernible borders or undiscernible borders? Because if it's the discernible borders, then it could be something that we could offer a potential like a resection for. If we can't see the borders, then it becomes very difficult to offer this sort of patient potential endoscopic resection. And then again, the similar approach to what we spoke about in the last podcast is look at the surface. What's our JNET? What's our pattern? Do we have an idea about what this risk of dysplasia is? In terms of biopsy, look, I think it's very reasonable to take a sample in these particular cases. Okay, so we try and dissuade people from taking biopsies from non-IBD patients and general polyps because the majority of the time, if we're seeing low grade on the surface, it's going to come back as low grade. But it's a little bit of a difficult ball game and a little bit more difficult at times to tell an IBD dysplasia. So I think 1 or 2 samples isn't going to compromise your endoscopic or potential for future endoscopic resection. One thing we also like to do is biopsy around the discernible area because we might find areas of dysplasia that we can't see to the naked eye. And we also have to try and obviously get an appreciation for how much active inflammation is there. Active inflammation really makes us dysplasia identification difficult. And so we really have to make sure we've optimized that inflammation as much as we can before we consider endoscopic resection, because endoscopic resection with any degree of active inflammation can be difficult.
Is there a approach, Ali, where if you're seeing maybe several areas of dysplasia, is there a point where it starts triggering the thought that this patient should be subject to surgery?
Yeah, definitely. So the first bit is characterize, estimate your risk of dysplasia, consider a biopsy, and then as you've sort of highlighted is you need to look hard for metachronous lesions. So lesions elsewhere in the bowel, because they're going to have a reasonably high risk of, I think, upwards of 20% of having another significant lesion in the bowel.
Yeah.
So we certainly never make those decisions at that index endoscopy to proceed with resection. We always have to then bring that back to that MDT that I flagged with you earlier and decide what is the best course of action for this patient, what's the risk of future dysplasia, and what's the risk of issues like recurrence and metachronous lesion. And then you take that to the patient, and that patient might decide and say, look, you've got multifocal lesions, the borders are difficult to discern, there's at least high-grade dysplasia, there's a high risk of progressive malignancy and adenocarcinoma, and certainly definitive surgery for a total colectomy might be appropriate based disease and phenotype. So all of these decisions need to be made MDT approach, and we certainly would always have these conversations with them and offer those options.
These conversations are related to ulcerative colitis. Do we think it applies the same to Crohn's colitis, Crohn's involvement of the large colon?
Yeah, I think with Crohn's, you certainly can obviously still see dysplasia-associated colitis, but it really would depend on the location of that disease and what their disease phenotype was. If they've had pan-colonic disease and inflammation, then that certainly could result in dysplasia in multiple areas of the colon. Although if that patient was only known to have, for example, proximal ascending colonic disease and early colonic disease, then actually the remainder of the colon may not necessarily have that same risk of dysplasia. And so, yeah, there's certainly some different nuances you would consider there, and perhaps a segmental resection may be all that's required. So we do need to consider that in terms of the disease distribution, the history of inflammation and inflammation burden.
Ali, thank you. How hard should a general practitioner push a patient? Let's suppose a patient isn't all that keen on seeing their gastroenterologist, seems to be reasonably well controlled, but not on biologics. We're talking about someone who perhaps is on a 5-ASA, some interval steroids from time to time, but their colitis generally isn't troubling them all that much, and they don't complain much, and they don't tend to have scopes often, but they see their general practitioner. What should the GP be sort of pushing them toward?
It's a good question. I think it's not uncommon where we have these patients who perhaps might be, a bit stubborn or
a bit reluctant to have things done. Yeah,
downplay their
a bit frightened to have things done.
Yeah, exactly. Or be frightened, as I said, downplay their symptoms. So we really need some objective measures of disease activity to determine what this patient's risk is. So I think A clinical assessment helps, but I do think we need some biochemical evidence. So we probably need some bloods, full blood count iron studies, and a calprotectin to really determine what is their degree of inflammation. And of course, the GP will have a strong understanding of what their past history was. So they will be able to, certainly have a degree of risk stratification themselves in the primary care setting to determine what that risk is. And I think in a low risk patient, as you we highlighted earlier, if they've never really needed much in the way of any steroids, their calprotectin's always been normal, they've never been hospitalised, and age-based colorectal cancer screening might be appropriate.
Yes.
But if someone's needed more advanced therapies, has had a history of severe colitis or severe luminal disease at some stage, then they really should be on some sort of surveillance schedule. And I think it's important to try and encourage and engage them for that. Yeah.
And when would that surveillance schedule start? Should it kick in at roughly 10 years from the diagnosis?
Yeah. So in patients who don't have a history of significant dysplasia or PSC, generally after about 8 years of index of diagnosis is when we start surveillance screening or dysplasia screening. In patients who do have one of those high risk features that I mentioned before, such as PSC, then we would start screening yearly from that time of diagnosis. And that might be important for a GP who might have inherited a patient from obviously another practice. They've been told they have PSC, or they're told that GP that actually that concerning polyps removed. Then they're the sort of times that alarm bells should be ringing and we should be doing yearly colonoscopies.
Yes. And if the patient is young when they're diagnosed, they might be diagnosed at 18 or 19. We're still applying that 8 to 10 year interval. Often a patient, they might seem young, they might be 27, 28, but we should still be starting our screening process
Exactly right.
for those patients. Yeah. Does that change significantly if there's a family history of bowel cancer? Should we be even more concerned? Do you know if that has an augmenting effect on their risk dysplasia developing?
With first-degree relatives and with a number of second-degree relatives, there can be a slightly increased risk in developing bowel cancer. So I think in that context, you would generally take whichever one of the lowest interval screening. If a patient had a family history of bowel cancer, but also had a history of previous significant inflammation, then as opposed to 5 years, you would look at doing 3 yearly interval surveillance screening. So yeah, certainly I think it does. I don't think it necessarily increases the surveillance interval more than that, other than the sort of personal high risk factors that we mentioned before, particularly with PSC and previous personal dysplasia.
Yes. So we should be remembering we try and get very good control of colitis. For people in private practice, they should be encouraging the patient to be screened on a regular basis from year 8 post-diagnosis and to seek some regular follow-up with their gastroenterology team. And it's behoven on us as gastroenterologists to take our time, carefully survey the mucosa, maybe use chromoendoscopy, as you said, or perhaps new technologies as they emerge and find their place in our practice.
Yeah, absolutely. And characterise, give a diagnosis, use the well-documented classification systems that we use to describe both polyp morphology and surface characteristics. You take lots of photos. I think it's really, you can't underestimate the importance of photos in the endoscopy setting, especially when you're then going to discuss with your colleagues. One thing we always do is we freeze photo. You're never going to get criticised for taking lots of photos, and I think it just gives you a lot of valuable information. And then with that information, discuss it with your colleagues who have a subspecialty interest in that area. They can take that to an MDT setting to determine what are the options. And of course, as we've spoken about in our other podcasts, is the patient being able to have a personalised treatment decision as to what they'd like to do next.
That's very helpful, Ali. Thank you for taking us through that so eloquently. Ali, give some advice. I know you're well on your journey now. Give us some advice to a younger doctor, perhaps trying to find their way in the mire of medicine. There's so many different areas that young doctors can consider they may pursue professionally. What advice would you give?
Yeah, certainly I still think really reasonably early on, but taken a few different turns. And I think when I think back, I guess, of where I am at the moment, I've just probably been very lucky and fortunate to have had some fantastic mentors within gastroenterology, whether that be hepatologists or IBD specialists or, and more recently colorectal surgeons. Being able to have a support network and a mentor is really helpful. And so it's good to try and connect with someone who you think you've developed a good relationship with in a sort of clinical setting. And I think you know pretty early on if this person has your best interests at heart, and they often guide you at different times of your career. So certainly have a mentor. And I think some good advice I had early in my sort of resident intern career is, you know, look at your consultants and look at sort of their general level of content and happiness and, their sort of job satisfaction. And I just thought that the gastroenterologists I worked with were great and really approachable and happy. So, you know, that's great advice too. And yeah, I mean, there are different challenges at different times. The intern and residency seems like a slog, but you just got to remember that is a finite period. And once you're in that sort of advanced training phase, I think that's when you really start to figure out what your passion is. That motivation, I think, will only rise and rise. So, take your time. You don't want to rush these decisions. Find mentors. And so I should also mention mentors who are potentially advanced trainees are helpful too, because they can help you along that journey as well. Yeah.
Ali, that's excellent. Look, thank you very much. And welcome back to Melbourne. Appreciate you bringing your expertise here and we look forward to catching up again soon.
Thanks, Luke. Pleasure. Cheers.
I'd like to thank you for joining me in this conversation held with Dr. Ali Eqbal on the subject of colon polyps. I certainly hope you enjoyed it as much as I did. For the next podcast, we'll have another very interesting guest and clinical problems to review, and I invite you to join me again then. During the podcast series, we will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as general information only and reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and may be emailed to manager@grhealth.com.au.